speaker for this session is Dr. Alex ROVIRA. Dr. ROVIRA is the head of the Neuroradiology section at the Vall d'Hebron University Hospital in Barcelona, Spain.
Well, thank you very much for the introduction. And first of all, I would like to thank the organizers, the president of the society and of this Congress, Renato Mendoza, and also the local organizers. It's a great pleasure, Tarek and Emad, for inviting me to participate in this meeting. Thank you very much. So for me, it's a great pleasure to be in Egypt again. And my topic today is to talk about how can we make a correct differential diagnosis between MS, multiple sclerosis, and other inflammatory demyelinating disorders. Particularly, I will talk about aquaporin 4, neuromyelitis optica, and also MOG antibody disorders. Oh, sorry. Oh. Okay, these are my disclosures that I don't think will have any impact on the content of my presentation. And let's first introduce this presentation with this cartoon in which you can see the different inflammatory demyelinating disorders that can affect the central nervous system. The prototype of these disorders is multiple sclerosis. It's the most frequent inflammatory demyelinating disorder. But in the last years, we have introduced different authors have introduced other disorders that at the beginning it was thought that they were variants of multiple sclerosis, but nowadays we know that are completely different disorders with different treatments, different prognosis, and it's extremely important to make a correct differential diagnosis between MS and these other conditions. And in this table you can see the difference between all these three disorders regarding the target, myelin or astrocytes, some demographic information. But I think that the most important thing that you have to keep in mind is that the prognosis is completely different. Poor prognosis in neuromyelitis optica, much better prognosis in MS, and even better with MOG antibody disorders. And also, the first-line treatments in these disorders are different, and in fact, some drugs that are very effective in multiple sclerosis produce negative effects in other conditions, such as, for example, in aquaporin 4. So that's why it's so important to make a correct differential diagnosis. So we also know that these three different disorders may affect different areas of the central nervous system, the optic nerve, the spinal cord, and also the brain. And we will focus on these three different topographies to make the differences between these three disorders. So first of all is the optic nerve. The optic nerve is commonly involved in all these three disorders and with different patterns. Usually in multiple sclerosis, the lesions may involve any segment of the optic nerve, but are more frequent in the intraorbital and in the intracanalicular segment of the optic nerve. The lesions are in the acute phase, usually unilateral, and usually preserve the optic chiasm, and the lesions are relatively short. And this is different from what we see in aquaporin 4, in which the lesions frequently are bilateral, involve the more posterior segments of the optic nerves, and it's quite frequent that they also affect the optic chiasm. And finally, in MOG antibody disorders, in MOGAD, the lesions are more frequently bilateral. It's quite frequent that they are simultaneously bilateral and involving long segments, but mainly of the anterior part of the optic nerves. Optic chiasm involving is less frequent compared to aquaporin 4. These are three different examples of these three different conditions. You see a typical short segment involvement with this 3D double inversion recovery sequence on the right side. This is a case of a bilateral involvement with extension into the optic chiasm, typical of aquaporin 4. And finally, this extensive long segment involvement bilateral in a case of MOG antibody disorders. But there are specific patterns that should us to suggest the diagnosis of MOGAD. And one is the presence of optic disc edema. This is a relatively common finding. You can see this edema that sometimes show even enhancement. And also another finding that is relatively common in up to 50% of the cases, when you inject contrast and you perform a coronal T1 sequence with fat suppression, you can see this perineural enhancement, something that has not been described in aquaporin 4 or in multiple sclerosis. And as I mentioned before, involvement of the chiasm is up to 20% of patients with aquaporin 4, similar in MOC antibody disorders, but in this case, this optic chiasm involving is usually associated with extensive lesions involving the optic nerve. So let's move now to the spinal cord. Very nicely, Professor Mendoza introduced some of the findings that can help us in making this differential diagnosis. But the first thing that we need to do is to assess the extension of the lesion in the sagittal view. And we know that in MS it's extremely rare that the lesions are long, usually are short. There are some exceptions in the pediatric group, but usually they are very short. And while this is not the case with aquaporin 4, in which the majority, almost all the lesions are quite extensive. In MOC antibody disorders, the lesion can be both short and longitudinal, and usually they combine both patterns in the same patient. Conus involvement, as you can see also in this example, is more frequent in MOC antibody disorders, while it's quite rare in the other conditions. Okay, but these are what we know, but this is not always the case, and these are two examples in which we could detect in a patient with short myelitis. This is case 1, this is case 2, both with short myelitis, suggesting the diagnosis of MS. But these patients, after a follow-up of a few weeks, they show an extensive longitudinal myelitis in both cases, associated with clinical worsening. And this has this pattern of follow-up has already been described in a paper published by the Mayo Clinics a few years ago. And they show that in up to 15% of patients with a final diagnosis of aquaporin 4, the first radiological finding in the spinal cord is a short segment myelitis. So keep this in mind, and also the concept that a short segment myelitis does not exclude the diagnosis of aquaporin 4. You have to be careful with this finding. Okay, and additional findings that are also quite useful, particularly for making the diagnosis of aquaporin 4, is the presence of the so-called bright spotty sign. And you can see this sign usually on the sagittal images on T2. You see there are areas inside the extensive lesion that are brighter compared to the rest of the lesion, and even brighter compared to the CSF. And this sign reflects, it seems that reflects a severe degree of tissue destruction, and also is associated with a poor prognosis of these lesions. This finding, particularly if associated with a longitudinal extensive myelitis, gives a specificity for the diagnosis of NMOSD close to 90%. So this is extremely important. And the second finding that also is quite useful is the line, the sagittal line sign. As you can see here, there is a line of high signal intensity, higher than the rest of the lesion, and this signal that reflects involvement of the central gray matter is quite common in MOC antibody disorders, in few cases in aquaporin, but has not been described in MS. Another sign that also has been proposed some years ago, in 2005, is the extension of this longitudinal extensive myelitis involving the cervical segment into the area postrema, the dorsal part of the medulla oblongata. And this is important from a clinical point of view because they explain why it's so frequent that patients showing these imaging findings have hycup and nausea, because the lesion involves these nuclei here that produce these effects. So initially it was thought that this was very specific for aquaporin 4 NMOSD, and we have several cases showing this finding, extension to this region. However, again, we have to be careful because this is not completely specific for for this condition. I'm showing you 4 different cases, in all of them with extensive lesion in the cervical segment extending into the hyperstrema. This is case 1, case 2, case 3, and case 4. So guess which one of these 4 cases is NMOSD? And the second question is, which is the most important information I'm showing you in this slide? The age. Age is extremely important, and in fact, whenever you see a patient over 50 years of age, you have also to consider alternative diagnosis. And in fact, these are the diagnoses. The first case was aquaporin 4. The second one is a B12 deficiency. This is a glioblastoma, and this is a dural fistula of the posterior fossa. So I think it's extremely important to keep in mind this graph. You have to consider the onset of the clinical symptoms, acute, hyperacute, chronic, but also the age. And as you can see here, whenever you have a chronic clinical situation, longer than 3 weeks, in patients over 50 years of age, 40, 45, always consider a tumor or a vascular malformation in your differential diagnosis. Okay, but now let's move to the pattern of these diseases in the axial plane. And we know that in multiple sclerosis, more than 95% of the lesions are located in the lateral tracts or in the dorsal tracts. In aquaporin 4, at least in the acute phase, the lesions usually involve almost completely the core transverse area. While, as I mentioned before, in MOC antibody disorders, the lesions have a tendency to involve the central gray matter, producing the so-called H sign in the axial plane. However, also we have to recognize that in some cases, MOC antibody disorders, they may have a pattern that is quite similar to what we see in aquaporin 4. These are examples. Again, the typical lateral and lesion involving the lateral segments, the lateral tracts also affecting less than 50% of the core cross-sectional area. This is a typical case of aquaporin 4 with almost completely involving the spinal cord, and also if you look carefully you can see the bright spotty signal here, and this is a very nice case of MOGAD with involvement of the central gray matter. And finally, this is another case in which the pattern is more or less similar to what we see in aquaporin 4. The pattern of enhancement is also important. We know that in acute lesions in MS, in the spinal cord, you may see a nodular or a ring enhancing pattern, very well defined. The lesions are relatively small. And this is not the case with enhancement that we can see in NMOSD, in which you can see this lens shape pattern, or what I think is more specific for this condition is a peripheral pattern, a kind of a leptomeningeal pattern. And also the duration of this enhancement is much longer in aquaporin 4 compared to MS. In MS usually it takes 3 weeks, 3 to 4 weeks, and we can see persistence of this enhancement in aquaporin 4 even months after the onset of the clinical symptoms. And finally, to mention that in MOC antibody disorders, it's very rare to see enhancement of spinal cord lesions. And then the last part of my presentation will deal with findings in the brain. We all know, we are familiar with the typical patterns that characterize MS, multiple sclerosis, small lesions, mainly involving the periventricular, juxtacortical lesions, intracortical, and also the pattern involving the corpus callosum and the brainstem, particularly the outer margin of the pons. But there is one additional emerging feature or finding that is very helpful in making a correct differential diagnosis, particularly in difficult cases in which either from a clinical point of view or radiological point of view we have doubts about the diagnosis. And this is the central vein sign. We know that the vast majority of lesions in MS, they are located in the white and also in the gray matter surrounding veins. And that explains the typical and the all finding of ovoid or Dawson fingers that characterize these lesions, in which the major axis of the lesions is perpendicular to the ventricular walls. But nowadays, thanks to the possibility to use susceptibility-weighted images, sequences, we can identify directly the vein inside this lesion. This is quite easy to do in clinical practice. And this is a summary of the different studies that apply this sign in MS and in other conditions, inflammatory and non-inflammatory conditions different from MS. And you can nicely see that if you establish a cutoff point of 40 to 50%, indicating that more than 40 or 50% of all the lesions that you see on T2, they will have this sign, you can nicely discriminate with a high sensitivity and specificity between MS and these other conditions. We will talk a little bit more of this sign in the other two disorders. What about the topography of the lesions, the presence of lesions in aquaporin 4? Initially, it was thought that the brain was spare in this condition. This is not true. And the majority of patients with this condition will show brain lesions. And where are these lesions located? Well, in those areas of the central nervous system in which there is a higher expression of this channel, the aquaporin 4 channel. And this is a nice cartoon from this paper. In the red line, you can see these are the areas with a higher expression of this aquaporin 4. So you should expect that the lesions are mainly located in these regions. And you can see here, surrounding the fourth ventricle, these linear lesions in the corpus callosum, also in the area postrema, as I showed you before, in the floor of the fourth ventricle, and also in the hypothalamic region. So these are the typical locations for lesions in this condition. However, in addition to these areas, and it's sometimes difficult to explain, but we can see these kind of press-like lesions in patients with aquaporin 4, or, which is quite typical, these longitudinal extensive corticospinal lesions also in this condition. And finally, this is a very nice pattern with these diffuse periependymal lesions that in some way looks like a lymphoma, but this is also quite specific for aquaporin 4, although not very frequent. So these are the patterns that you have to keep in mind in order to make a correct differential diagnosis. So different authors have tried to establish some criteria, very easy criteria, to make a differentiate MS, multiple sclerosis, from aquaporin 4. This is one of the studies that was performed in Oxford in the UK, and they used a very simple findings: location of lesions in the periventricular and in the inferior temporal lobe. This is a very extremely useful area. We see a lot of lesions in MS in this region, also involvement of the U fibers, the juxtacortical white matter, and the presence of Dawson fingers, ovoid lesions, again very frequently seen in MS. So whenever you have a patient in which all these findings are negative, and you can see this algorithm, then the possibility that this corresponds to aquaporin 4 NMOSD is extremely high, and you can almost exclude the possibility of MS. So very easy to use in clinical practice. More recently, Carciaghera from Italy proposed another set of criteria, also very easy to implement. And you need to fulfill at least 2 of the following 5 criteria in order to make a diagnosis of NMOSD. No juxtacortical or cortical lesions, absence of periventricular lesions, these are cases of MS, absence of Dawson fingers, these are negative criteria, 3, and now the 2 additional criteria are positive. You have to demonstrate long transverse myelitis or periependymal lesions such as the one I showed you before. So you have at least 2 of these findings, then you can establish a diagnosis of the possibility of that this will correspond to aquaporin 4 is extremely high. What about the brain MR findings in MOCAT? MOCAT is a relatively new disease. Initially it was grouped together with neuromyelitis spectrum, but now it's considered a completely different disease, and the findings are very similar to the classical findings that we know from ADM, acute encephalomyelitis. In fact, acute encephalomyelitis, at least in pediatric population, more than 50% of these patients showing this syndrome will show positivity for MOC antibody MOC antibodies. So the pattern is different from MS. Usually you have relatively large but a few number of lesions involving bilateral, the brain hemispheres. You can see also the lesions usually are poorly demarcated and fluffy. It's quite typical to involve the brainstem and the middle cerebellar peduncle, particularly in children. Leptomeningeal enhancement, as you can see in this particular patient, is quite common. And particularly in patients presenting with an ADIM-like syndrome, in these patients you can see these very large tumefactive lesions showing in some cases enhancement. But you have to keep in mind also that in up to 50% of patients with this condition in the adult population will show no abnormalities in the brain, because mostly in this population the areas that are involved are the optic nerve and the spinal cord, with no involvement of the brainstem, of the brain. Some people try to make a differential between MOCAT and NMO, aquaporin 4 NMO. This is an attempt from Cobo Calvo, and you can see that, for example, involvement of the thalamus, of the pons is more frequent in MOCAT compared to aquaporin 4, while the involvement of the medulla oblongata and area postrema is more common in aquaporin 4 antibody disorder. So these are topographies that are also useful to consider in your differential diagnosis. Another attempt was established by a recent paper that was just published a few weeks ago, in which they analyzed the number and the volume of the lesions that you can see in the brain. And as expected, the number of lesions is much higher in MS compared to the other conditions. If you assess the volume, still the volume is higher, significantly higher in MS compared to the other two. But the difference is smaller. And the explanation for that is that in MOCAT and in aquaporin 4 we have less lesions, but are bigger compared to the lesions that we see in MS. Unfortunately, when they try to make a difference between MOCAT and aquaporin 4, there are no significant difference. So it's extremely difficult from a radiological point of view to discriminate between MOCAT and NMO-SD. This is another option to make a differential diagnosis, is to assess the presence of cortical lesions, purely intracortical or juxtacortical, very common in MS, particularly if you perform a double inversion recovery sequence or a heavily T1 weighted sequence. You can detect these lesions in more or less 50 to 70% of MS patients, but it's very rare to see this type of lesions in the other two conditions. And unfortunately, again, we cannot really use this sign to discriminate between MOCAT and aquaporin 4. And the central vein, we are discussing this back. This is a nice example. This is a lesion in the periventricular white matter with a dot inside, a black dot indicating a vein. And again, it's very common to see in more than 40 or even 50% of all the lesions that we see on T2 in MS to see the central vein, while this is very uncommon in the other conditions. So in difficult cases, use the central vein in order to make a correct differential diagnosis. And finally, the follow-up. The follow-up also is completely different between MS and the other two conditions, because in MOCAT and also in MOCAT, most of the lesions completely disappear, reflecting that they mainly are an expression of an inflammatory condition with edema, but with no significant tissue destruction. So this is a nice case with a lot of big lesions in the subcortical area involving both brain hemispheres, and these, after a few months, the lesions all disappear. This is not the case with MS, in which the tissue destruction is there, also in NMO-SD, and therefore most of the lesions remain visible on follow-up images. So I will finish here. I think that we, as radiologists, we play a very important role in suggesting these three different diagnoses. We have to be familiar with the different diagnostic criteria that have been published. For MS, the last version was published in 2017. It's expected that in the next year we will have a new version of this criteria that probably will introduce some significant changes. We have also the criteria for NMOSD published in 2015. These criteria are completely old-fashioned. I think that it's clear that we need a new version, and I'm aware that people is working on that. And finally, very recently, a group of experts led by Brenda Bangwell from Canada, they published this very nice criteria, very useful to use, and you will understand if you read these 3 papers how relevant is MRI in suggesting one of these 3 diagnoses. Thank you very much for your attention.
Thank you so much to our speakers for a truly comprehensive session covering neoplasms, infections, and degenerative changes. We have about 10 minutes for questions. So I believe that there's a mic that our audience can use if anyone has a question. Please don't be shy. You have some world experts here. Yes, I see a question over here. And to our speakers, you have a handheld mic beside you.
Professor Bello, please. Thank you, Professor Bello, for very nice presentation. I'm just asking about your cases number 6 and 7. In fact, they were totally different in the advanced MRI. They were different in perfusion. Case 6 was hypoperfused and with normal choline NAA. The case 7 was the reverse. It was hyperperfused and the choline creatine and choline NAA ratios were high. So I think that seeing as common is common, we were diagnosing case 6 as a non-neoplastic process. In fact, it was an astrocytoma grade 2. I'm just asking your initial diagnosis in that case. Was that a tumor? And really how to differentiate in such tricky cases. I thank you again.
So thank you for the question. And for the case that was the grade 2 astrocytoma, we first thought that it was a low-grade tumor. And why didn't we think of something non-neoplastic? If you remember, the FLAIR imaging did show the surrounding white matter pattern of edema that we thought was a bit more likely to be neoplastic. Also, the presentation with seizure in somebody of that age, you'll remember they were 24. And if you just take seizures, no imaging, let's say all imaging is down. So in a child, it's going to be a congenital malformation. In an adolescent, more likely starting to be brain tumor, as in somebody who's 24. And then once you are over the age of 50, I'm in that category right here, over 60, it's more likely to be a result of a prior infarct that affects the cortex. So again, we were taking a lot of the clinical situation into hand. I don't know what sort of a non-neoplastic lesion that might have been. Certainly not demyelinating infection because of the diffusion. It was too much white matter for infarct. So I think that really we were left with neoplastic, but quickly went to low grade most likely. Can't rely on the enhancement as those 2 cases and many others have shown.
Thank you very much.
Thank you, Dr. Bello. Do we have another question over here on the right? Thank you. Yes, go ahead.
Thanks a lot. I have 2 questions. One is also for Professor Bello concerning the case with hemorrhagic infarct. The case with hemorrhagic infarct, sinus thrombosis. You rely on gradient recall echo, GRE, and it was bright, the vein was bright, but actually what we have learned also that it's usually dark on GRE, the sinus when it's thrombosed. So, but here it was bright.
I'm not sure I understood the question. The case of sinus thrombosis you are referring to,
Yeah.
you're asking about the low signal on the GRE?
No, actually, I mean the sinus itself, it was bright on GRE.
So the sinus itself being
Yes,
bright
yes.
on GRE?
Yes,
So this is because there was slow flow still in the sinus. So not necessarily the clot itself bright, but the slow flow in the sinus due to the partial thrombosis.
okay, thank you. The other question is for Professor Renato. How about modic type 1 for differentiation of spondylolischitis? Actually, it may be also high on stir, it can enhance for modic type 1 end-plate degenerative.
Yes. Well, if you consider modic type 1 is a kind of infection, there are several experiments showing that there may be slow infection. So it's really impossible to know that. There is a sign described in the literature that is to use diffusion-weighted images and to try to show the differences. But the experience is very low, and I don't really believe that the sign is valuable. I think it's it was just published. It's a clinic-made diagnosis. So the finding of the disc may help, because on degeneration you have low signal in the disc on T1 weighted images, and with infections you have high signal, but sometimes you have cystic degeneration of the disc. Sometimes it's impossible, and you have to rely on the clinics. That is very typical with the situs. The patient cannot move himself, it's very difficult, and on the laboratory data, C protein reactive. But it's a very tricky situation. Not always possible to make the differential diagnosis.
Thanks.
Thank you.
Thank you. I think I see a hand up at the back. No? Any other questions for our speakers?
I have one for Dr. Rovira.
Yes, please go ahead.
Are there differences in the treatment of MOG and aquaporin 4?
Well, there are no big difference, but usually you don't use immunosuppressants for MOG antibody disorder. You treat the patients with steroids. They have a very good prognosis, and particularly if the MOG antibodies disappear after a few months, so they are potentially reversible. So the treatment should not be as aggressive as we do with aquaporin 4, in which we have to use immunosuppressants, particularly B-cell depletion, which is not used at all in MOG antibodies.
Okay, any other questions for our speakers? I am seeing none, so our next activity is a coffee break, but please be back in your seats at 5:30. We're going to have our opening ceremony, and our two highest honors for the International Society will be presented. So please join me in thanking our speakers, Dr. Bello, Dr. Mendonça, and Dr. Rovira.